I'm going to talk quite a lot about neuroscience, which in the first instance may not feel immediately relevant. I started thinking about this set of ideas that I'm going to talk about 6 years ago when I gained funding for a psychoanalytic service for people with severe personality disorder in the NHS. So I'm very interested in finding ways of making sure that psychoanalytic psychotherapy continues to have a presence in the NHS, and it seemed to me that one of the places where it's most relevant is in the most severe and complex patient group. So we managed to get a £1.6 million investment in a psychoanalytic psychotherapy service in Devon. And it was on the basis of finding the high-cost patients across the whole of the public sector. And the area of mental health where the most money was being spent was in out-of-area placements. So we have a threshold for our service, which is, for those who work in the NHS, a HONOS score, cluster 8 patients, who have a severity score of 8, 10 or above. So we select out a very severe and complex group of patients. And it turns out that that group of people is very interesting indeed from the theoretical point of view, and also that they're a group of people that largely services feel they can't treat. We're developing a new model called the Relational Affective Model, which I'm going to try and talk to you about. And in order to try and work out what is the basic problem with these patients that we're trying to resolve, I've had to kind of come up with quite a lot of theoretical adaptations of psychoanalytic theory based on neuroscience. So this is my attempt to make sense of what is a very complex and interesting group of patients. What characterises this group is that they're both severe in the sense that their levels of self-harm are sort of off the scale. They need sort of 2 or 3 people to stop them wanting to kill themselves all the time. And so they end up going to placements because they need such high levels of nursing staff to prevent them killing themselves. But they also are highly complex, so they tend to have a high level of comorbidity. The characteristic comorbidities are that they have a personality disorder, and eating disorders, they somatize, they tend to use substances, and many of them also have an autistic spectrum disorder. So what I want to describe to you is what I'm calling the relational affective hypothesis, which is the theoretical basis of the model which we're developing. The hypothesis describes a neurological, interpersonal and intrapsychic process through which the capacity for symbolization develops. And I propose that failures of symbolic function explain the co-occurrence of these comorbidities. I argue that deficits and defences at different levels in this process, or pathway, account for the different symptom presentations. Scientifically speaking, the hypothesis must be tested and potentially falsified. The lack of falsifiability has been a common criticism of psychoanalysis. In this respect, psychoanalytic thinking operates in a different domain from that of the wider scientific community, of which neuroscience is a part. And these domains often seem unrelated. Psychoanalytic psychotherapy is concerned with intrapsychic processes arising in the transference, and with personal meaning, which, as Blass and Carmelli, who commonly take issue with neuroscience being applied to psychotherapy, as they put it, personal meaning stands beyond objective descriptions. From this point of view, it's sometimes assumed that an interest in neuroscience is based on a naive assumption that locating analytic processes in the brain will provide evidence endorsing the analytic model and method. Antipathy to this is hardly surprising when premature or prescriptive applications of neuroscience to clinical practice are made. Furthermore, neuroscience developments may be perceived as emblematic of a cultural tendency towards treating evidence as fact. This bears little relation to the tentative state of our understanding of the mind and its relation to the brain and its disorders. I suggest that the mind, as experienced by the subject, falls within the field of psychoanalytic inquiry, but that it's neither subordinate nor superordinate to the biological perspective that neuroscience offers. These are different points of view on the same object, the brain, mind, and that both biological and psychological determinism represent failures of thinking. So the difficulty lies in bringing these two perspectives, psychoanalysis and neuroscience, into relation with one another. So I'll start with a clinical description of an average patient coming to our service, just to put you in the picture about the sort of people I'm talking about. So Miss A was a young woman who hardly socialised, hadn't got any particular psychiatric history by her late 20s. She worked relentlessly and seemed compelled to meet the demands placed upon her by other people. She had a fall at work, injuring her foot, and was advised to go home and rest. Although she had self-harmed and restricted her eating for a short period during her teenage years, she'd never seen a psychiatrist before. But during the days after she went home to rest, she made several attempts to hang herself without there being any obvious reason. There were no sort of precipitating things in her immediate environment that would account for why she'd be wanting to kill herself. She refused help, saying that she wanted to be left alone, at the same time as doing these very dangerous things, which meant that people felt obliged to step in. She described her family as emotionally remote and intolerant of disagreement, and as a child her speech had developed late, and at times she'd stopped speaking and eating altogether. In early adulthood, she'd gone through periods of falling unconscious, sometimes for hours at times of stress, which remained unaccounted for. And now all of those symptoms that had sort of popped up at various points in her development emerged together. Months of neurological investigation of these periods of collapse could reveal no physical cause. She would lose consciousness, become mute, stop eating, and dramatically lose weight. She said she wanted nothing from other people, but her actions ensured that she must be responded to for her safety. Psychiatric admissions under the Mental Health Act ended up with further escalations of her self-harming behaviour, and she was sent to an out-of-area placement. In the locked unit that she was sent to, her symptoms persisted, and she seemed to evade all attempts of any therapist to engage her in anything at all. It seemed that her primary objective was to stay one step ahead of the nurses and therapists who were working with her, and to make sure that she wouldn't at any point engage in any of it. After about 1.5 years of this, she was finally discharged on the basis that they felt that they were doing nothing productive with her. At the point of discharge, I assessed her for our service, and so this was a sort of slightly more psychoanalytic view of her. She was at first withdrawn and hardly spoke, but then gave me an articulate but fabricated account of her childhood. When I pointed this out to her, that she was ensuring that she behaved in a way that she wouldn't be discharged from services, but nor could she put herself in the position that she could use anything to get better. She responded by saying to me that she was in my system, as she put it, because I was seen as having oversight of this pathway, and that she must try and get out of it. And I commented that she was relating to me as though I was a spider whose web she was in, and she must extricate herself from it if I was not to consume her, with which she agreed, going on to say that she always managed by maintaining minimal contact with others through incessant work, and when work collapsed, so did she. For her, therapy would result in complete collapse and permanent loss of her independence, which she saw as a dilemma which she felt was insoluble. So that would be a sort of fairly typical first presentation. So I'm going to take you through quite a lot of concepts fairly quickly. The first one I want to talk about is the pathway through which symbolization happens in the brain. The second was a particular theoretical idea, which is Ron Britton's idea about projective identification in narcissism and how that relates to this particular theory. I then wanted to talk about xenophobia and psychic atopia, which some of you might recognise from Ron Britton's writing too. I want then to talk about what neuroscience tells us about how the mind relates to the body in narcissism. And then I want to talk about how that pathway that I'm going to describe is interrupted in autism, anorexia, somatization, and personality disorder. So this is the pathway that I'm proposing mediates the development of symbolization in the brain. As you'll see, it has two axes. It has a vertical axis, which I'm calling the affective axis, and a horizontal axis, which I'm calling the relational axis, hence the Relational Affective Model. Just to start by describing the affective axis. So Panksepp is a neuroscientist who has done research on rat brains for about 25-30 years and identified in this part of the brain the neocortex, which is the new bit of the brain that is much more developed in humans than other mammals. So he's identified what he calls 7 basic emotion command systems in that part of the brain that runs from the top of the spinal cord here up to the limbic system. Well, these are 5 of them. I haven't talked about the lust and the care system. These are neurological systems which have neurotransmitters which are specific to those systems and different from each other, and they each mediate different forms of affectively motivated behaviour. So they organise behaviour to meet homeostatic demands, to keep the body in homeostatic balance. They're part of your survival system. So the seeking system is the system which mediates foraging behaviour in animals, makes you go out and find in the environment the thing which will satisfy your appetite. So it's different from appetite. So it mediates exploration, curiosity, foraging. Whereas the panic system, which is an opiate and oxytocin system, mediates separation distress. and promotes attachment behaviour. It's painful for a lamb to be separated from a ewe, and the pain of separation is moderated by proximity. So the seeking system takes you out into the world, and the panic system keeps you close to the people you love. Then the fear and the rage system are in response to threat in the environment. So there's anxiety that's related to separation in the brain, and which is the panic system, and then anxiety that's related to threat, so predators in the undergrowth. The fear system is a separate system, separate neurotransmitters, different bit of the brain. And it's much more closely related with the rage system, so that would be a sort of fight-flight set up as a way of dealing with threats to one's well-being in the environment. And then another interesting system that I won't be talking very much about is the rough and tumble play system, which seems to be a way that young mammals sort out who's who in social hierarchies. So we are receiving from our body messages through our spinal cord and our hormones to the brain, telling us about the state of the interior of the body. And those inputs are organised by the basic emotion command systems into clusters of affect. And there's also visceral sensation that will tell the body that your heart is beating fast or your stomach is churning. Those inputs from the interior of your body will then be processed in a part of your brain. This area, the insula, serves to integrate sensory experiences from the interior of your body with sensory experiences from the external world to provide you with an experience of my feeling about that thing that's going on in the world at this moment in time. Our experience of the world is informed by our gut feeling as well as our sensory experience of the outside world. And those things are integrated in the insula, and that's probably the first time things come to be experienced in the mind, if you like, as opposed to in the body. There is kind of direct experience of the world. There's no symbolisation as yet. What I'm suggesting is required for those direct experiences of the world to be translated into something that's symbolised is the engagement of the relational axis. The relational axis has two parts of it. There are two large-scale neural networks that mediate self and other in the brain. There's a lateral network, which mediates here and now social interactions with the other. And there's a medial network in the middle of the brain, which does the internal processing of what's going on with self and other. And that's called the default mode network. I'm dividing those into what I'm calling domain 1 and domain 2. So these are relational domains in the brain. Domain 1, the right frontolateral parietal network. So this is a part of the brain that develops, as if you've read Alan Shaw's work, it's the part of the brain that develops in a relational context during that critical period in the first 2 or 3 years of life. It's connected with a mirror neuron system, which allows baby and mother to be attuned to one another. And there's an ongoing prosodic communication in the background all of the time that we're talking. So language is, in a sense, a sort of later developmental frill on the edge of that prosodic system, which is much more ancient and part of our developmental progression in infancy. And there's plenty of evidence that babies' limbic systems move in concert with mothers' limbic systems through the link that's provided by this mirror neuron system. Domain 2 is the vault mode network, which is a cortical midline structure down the middle of the brain. What happens in that area is what's called abstract evaluative processing of self and other. These are the things that we turn over in our minds when our executive functions are switched off. So when you're concentrating on a task, your default mode network is not very active. But when you're driving your car and you're not really quite paying attention because you're preoccupied with what you're doing that evening and you're thinking about the conversation you had earlier, that sort of activity is default mode network activity. So it's not the here and now, what's going on between you and another person. It's the way you ruminate and turn it over in your mind internally afterwards. And that system is active in what's called task-unrelated imagery and thought. That's what TUIT is. So the cognitive neuroscientists call that task-unrelated imagery and thought. And most of that is about, so that task-unrelated imagery and thought is about social interaction. So there's an external world system for social interaction, and there's an internal rumination which goes on, which is a sort of processing what's going on socially. What has all this got to do with symbolisation? Peter Hobson is a psychoanalyst who was interested in research, particularly in autism and borderline personality disorder. So he was interested in finding out what mother and baby interactions preceded the development of autistic symptoms. He developed an idea about the ordinary developmental processes which go on between mothers and babies, which underpin developing the capacity to symbolise, and how those go wrong in autistic disorders. So he looked at a group of children who had autistic older siblings. Because autism runs in families, these were children who were at risk of developing autism, and he was trying to differentiate from the beginning what went on in the relational process with mother. What he arrived at was the idea that in normal development, babies come into the world with a system which he calls the child in relation to other. The system, the child in relation to other, orientates the baby towards mother's face. Mother's face is emotionally salient to the baby. And that seems to be the basis for the sort of dyadic, non-verbal conversation that goes on between babies and mothers during the first year of life. Up until about 1 year old, when a developmental change happens. And so Trevarthen talked about this as the move from primary intersubjectivity, which is a dyadic process, to what Trevarthen calls secondary intersubjectivity, which is more triangular, more like this. At about the end of the first year of life, if mother points to something, instead of looking at mother's hand, the baby will look at what mother's pointing at. So they have arrived at the point that they have an idea of what mother has in mind, rather than what is immediately present on the surface. So the baby is able to move from the point of view of seeing the world as they see it, to putting themselves in the other's shoes and being able to think about what the other might be thinking. Hobson's point about this is that if that triangulation happens, then 3 important developmental progressions happen after that, one of which is language, the other is symbolic play, and finally, as a later development, the capacity for abstract thought. So what he says is happening in autistic children is that they are not born with a system child in relation to other, as normal children are. So they don't tend to orientate themselves towards mother's face. They're not engaged in the dyadic interaction with mother, and as a result, they don't get to the stage of triangulation. And if the stage of triangulation is missing, this is a sort of nodal point in the development of the capacity to symbolise. So those other 3 important developments, which are language, symbolic play, and abstract thinking, don't develop. And he corroborates that by demonstrating that children who are born with congenital blindness are unable to see their mother's faces do have autistic symptoms until they reach the point of finding another route, apart from the visual route, for finding their way into the mind of the other. And then the autistic symptoms tend to resolve over a period of time. And that babies depend on their mothers to lift them through the dyadic interaction from an egocentric view of the world to the point that they can see the world from mother's point of view, which in cognitive neuroscience is called the allocentric point of view. So that is a very different matter, I think, from what we talk about as triangulation from a psychoanalytic point of view. There is obviously a similarity with an Oedipal triangle, but we're not talking about the same thing, are we? So what's the relationship between that external world triangulation thing that goes on between mothers and babies and what we talk about in psychoanalytic terms when we talk about triangular space, as Britton does, and the Oedipal situation and so on? This is Britton's description of how the collapse in internal psychodynamic triangular space happens. He talks about a situation in which either a baby is completely intolerant of mother's separateness, or the mother's completely unable to accommodate herself to the baby, to the extent that the baby divides their internal world into a part that I'm in control of, which I call the mother, and that all of the potential disagreements and differences get projected into father, who can't be allowed to get together with mother. So that results in a collapse in what Britton calls triangular space. So basically you end up with a divided emotional world in which there's an object who is mother, who would be with you all of the time and perfectly united with you, if only it weren't for father, who's always getting in the way. And so all of the feelings about the hatred of separateness get located in dad, who has to be kept out of the picture. So there's an intolerance of difference, and the feelings about difference are all projected into father, so the Oedipal scenario can never be allowed to happen. So you'll be pleased to know that we're at the top of the symbolic function pathway now. We're nearly there, nearly finished. So in the brain, there is an area called the angular gyrus, which is responsible for what are called the semantic aspects of language, symbolization, metaphor, and abstract thought. So this is an area of the brain that's unique to humans. It's not present in any primates. It developed out of the part of our brain which is responsible for tool use. And so there seems to be a correspondence with being able to manipulate tools in external space and manipulate ideas in the mind. So the angular gyrus, as a new development from the tool use bit of the brain, is responsible for being able to use language, symbolise, and to make metaphors. So if you have a stroke in that bit of the brain, you can't do any of those things. So my argument is that in order to symbolise, you need both affective engagement, like the non-autistic child, and you need relational engagement. And you also need a bit of kit in your brain called the angular gyrus, which allows us to use that raw material of experience to come up with language, abstract thinking, and metaphor. That's a kind of summary of the relational affective hypothesis, that all those things are needed. So our patients could have a problem with the biological system. They could have a deficit, which means that they're not able to relationally engage, like the autistic children do. Or they could have a problem with the relational context, which means that their mother is unable to lift them out of the egocentric to the allocentric point of view. Or they could have psychodynamic defences, which mean that they are unable to allow themselves out of either a hypersubjective position, as Britton puts it, or a hyper-objective position. But either way, symbolisation fails. And it would be really useful to know which of those things it was, wouldn't it? Because you might decide to intervene in a completely different way if it was one thing as opposed to the other. We aren't anywhere near being able to tell which it is yet, but those seem to me to be important questions. So Britton's ideas about thin-skinned and thick-skinned narcissism and acquisitive and attributive projective identification. He quotes Ray saying that what the infant has most difficulty with is getting to grips with the fact that the reality that the other is at once needed and good and separate. You can either get rid of the otherness of the other, and he'd call that an acquisitive state, where you treat the other as though they're a part of yourself. Or you can get rid of the need for the other, which he calls an attributive state, in which basically you believe yourself not to need anything. And all neediness is projected and disavowed and put somewhere else. It doesn't belong to me. So there's two solutions to this narcissistic problem. So the acquisitive defence that he described is what he calls thin-skinned narcissism. So in thin-skinned narcissism, mental and bodily attributes of the other are treated as though they belong to the self. So when I'm with a patient in the most profound thin-skinned state, which some of our patients go into in the course of the day, they could go into an akinetic mute state in which they completely come to a halt in the middle of the day and are unable to move or speak. And if I say, lift your right arm, they will lift their right arm as though it was my arm. In their mind, their experience is that I am the mind and they are the body, and we are one creature. They are at a very extreme version of an acquisitive state in which they really experience themselves as an extension of the therapist, of me. We've had people stopping with their hand on the door handle just as they're about to leave, literally coming to a stop, unable to get out the door. So it's the point of separation that produces this kind of state. So in this state, you are me, we are one and the same person, and otherness is denied, and two minds are felt to be as one. So the mother is related to as though she and the baby exist in the same skin, and all that represents separateness is attacked in this state, and what Britton describes as objectivity is intolerable. So this is what he terms as a hypersubjective state, meaning that one is a state where one only has a subjective position and is completely unable to put oneself in the feet of the other and view oneself from an objective point of view. So in the thick-skinned state, painful and threatening attributes to the self are disavowed and treated as though they belong to the other. My favourite example of this is of a lady who came to our service and on the first day defecated on the floor of the toilet. And she had gone into the toilet just after I had, and then nobody would admit that it was them that had done it. So we had to have a community meeting to try and work out who was responsible for clearing this up. And as we sat down and had the community meeting, she turned around and looked at me and said, "It was you that did it, Dr. Mizen. I went in after there and you did it." So I said that even though it was Monday morning and not a great day, I didn't think I had done it, but I knew enough about her to think that it perhaps had been her. And there was just a moment of where you could see the defence crumbling, and then she sort of recognised that it was her that had done it. So that attribution and disavowal is so profound, it really does feel like it's the other person. There's no as if in it. It really literally feels as though it's true. So in that state, I am you, and the subjective connection with the disavowed part is lost, and one mind is felt to have become two. Dependent parts are projected, and the patient behaves as though they need nothing and can provide everything for themselves. Subjectivity in this state is intolerable. So you'll find patients talking about themselves in diagnosis terms, or as another being. They don't relate to themselves as this is me. So that's a hyperobjective state. Okay, so this is just a sort of a picture to kind of simplify the ideas. So the blue circle is the thin-skinned state, acquisitive state, in which the patient mostly occupies the baby position and all adult functioning is projected into the other. The patient becomes more and more infantile. In the other state, the patient tends to adopt the mother position and everything infantile is projected into others. The black line represents the disavowal of that part of the self. So in the acquisitive state, two people become one, and in an attributive state, one person becomes two. So this is the relational affective formulation, which is the same colour scheme as the previous slide. This is the formulation that I would say that every single patient in our service, you could say this is true of their internal world. So they operate in two states of mind. They're very claustroagoraphobic. The blue is the acquisitive state of mind, the red is the attributive state of mind. The blue is thin-skinned, the red is thick-skinned. The blue is agoraphobic, so in that state, the person is afraid of the external world and wants to get inside. So in the face of separation, they want to get inside. They divide their loving feelings so that it feels as though they only love the other and want to be with them. And their impulse is to get inside the object, thought in object relations terms. When they do get inside, they get into hospital, they tend to become increasingly regressed. So unlike more neurotic patients where they become regressed in the transference and you make an interpretation and they become more adult as a result of the insight that comes from the interpretation. If you understand these patients, they experience you as getting closer and they become more regressed. So understanding is a problem to them. It's threatening to them because it pushes them into a more regressed state. They want to be inside you almost immediately. So, which causes all sorts of technical difficulties doing work with them, because the better you understand them, the worse they become. Once they've got inside, then there's the dominant anxiety becomes one of getting trapped inside something they can't get out of. So what characteristically they'll do anything within their power to get admitted to the ward, and as soon as they're in, they'll be desperate to escape. So there'll be lots of fights going on with nurses at the door of the ward and so on. So once they're in that agoraphobic state, if you were to present them with anything in your mind or your behaviour that showed them that you were separate, that would be on the receiving end of their aggressive feelings. So you get attacked for your separateness. The affect in terms of the mood state that goes with that is a depressed appearing state in which the person seems very slowed up and withdrawn and is often misdiagnosed by psychiatrists as depression. So going to the thick-skinned state, people seem to feel frightened of and hate their loving feelings for the other. They're a threat. If I know I love you and need you, then I'll be trapped. Therefore, I have to just behave as though I don't need you and don't want anything to do with you. So in that state, they want to be as far away as possible. They want to be outside the object because they're terrified. They're claustrophobic. They're terrified of getting trapped. Like my lady who was worried about the spider's web. And will adopt a position of pseudo-independence. So this isn't the sort of independence which means that you have a dependable good object inside you. This is an independence which is reliant upon the denial of need. So in that state, any connection with the other or the object has to be attacked because it's a threat. Patients tend to present as manic. They're rather grandiose, they feel they can provide for everybody, they don't need sleep, they don't need food, they don't need anything. They can do it all themselves. So often the person will be giving a very double message, like the lady I described, that she is, every one of her actions is designed to put other people in, but in her head she thinks, I don't want anything to do with any of you. So she's doing both at the same time. They're caught in an emotional world where closeness is terrifying, distance is terrifying, and they're bouncing back and forth between the two states. So the kind of emotional instability, the ups and downs of borderlines are kind of driven by that dynamic, I think. Okay, so just to say that this relates to Britton's triangle in the sense that on the left-hand side of the diagram you want mother without father, and on the right hand of the diagram you want father without mother. But there's a divorce between those two states of mind. You can't bring the maternal and the paternal principle together in mind. You've either got one or the other. So there's no triangulation. So Mark Soames, he did psychoanalytic studies with people who had brain lesions in various sites. And one of the group of patients that he studied were people who had what are called right hemisphere lesions. So those are strokes in the very area of the brain that does the here and now relating between self and other. Most medical students, including myself, learn about the right hemisphere syndrome is that it's very different from people who have left-sided stroke. So if people have a left-hand stroke, they may have lost their capacity for speech, but they tend to be appropriately depressed about the fact that they've had a stroke. They recognise that they have a paralysed arm, and they feel that they're, an appropriate sense of the catastrophe that's just happened to them. Whereas for people with the right hemisphere strokes, the clinical picture is very different, and it's quite hard to account for it from a neurological point of view. There's a denial of the fact that the paralysed arm is paralysed, and that's called anosognosia, denial of deficit. If you pick up the paralysed left arm and say, "Is your arm working?" the person will say, "Well, it's a little bit weak today, but I think I slept on it awkwardly." They'll make up a story, so the confabulation will be a wish fulfillment. Sometimes, not in all people who've had these strokes, they will say that the paralysed limb doesn't belong to them, it belongs to somebody else. So they sometimes will name it after a person who they have previously lost, like a relative who's died. They'll give it the name of the somebody who they've lost. And in a few patients, they hate the paralysed limb. So probably about 5 or 10% of people who've had right hemisphere lesions will start attacking the limb. There are various theories that have been put together by neurologists trying to account for these bizarre symptoms, but none of them seem to fully explain it. So Mark Soames has had a go at explaining it using a psychoanalytic model. Now the curious thing is that if you put ice cold water in the left ear of a patient who's had a right hemisphere stroke, that's called the caloric test, it's a neurological test. You put ice cold water in their left ear, and previously they denied they had a deficit, and you pick up their hand and say, "Is your arm paralysed or is it working today?" They'll say, "I had a stroke 3 weeks ago, it's an absolute disaster. My life is in pieces and I don't know what I'm going to do with myself." And then 8 hours later, when the caloric test has worn off, if you pick their arm up again, they'll say, "It's a little bit weak today, I slept on it," and it's they'll be back to the little fib they're telling themselves. And so Ramachandran, who's a neuroscientist and not at all a psychoanalyst, he did that experiment and was completely unable to come up with any explanation apart from the fact that the anosognosia, the denial of deficit, is a defence. Then Mark Soames did psychoanalytic studies with people who had right hemisphere lesions, and what he found was that after a time, in the presence of the therapist, the patient would start saying, "I'm not able to cooperate with my physiotherapist because I can't seem to get to grips with the fact that this thing's happened to me, and I'm worried that if I don't, I won't get better." And if the therapist persisted with talking about their difficulty in facing the loss, there'd be a breakdown of the defence, and they become very tearful and very upset and say, "Yes, I know I had a stroke, but I can't bring myself to think about it." But they couldn't retain that without the presence of the therapist. So in a sense, you could say the object constancy, that bit of the brain with the internalised mother that had developed it, was no longer there. So this is a description of one of these right hemisphere patients in a psychotherapy session. So the therapist has gone to see the patient on the walk, they're not well enough to get up from their bedside. He presents as aloof and egocentric and imperious, oblivious to the world around him, except in so far as it affects his own well-being. He appears unable to see things from the other person's point of view. He only took the initiative to address a complaint. He took nothing in and never expressed gratitude, seeming to have withdrawn into a cocoon of self-sufficiency. And yet he was simultaneously very needy and demanding. He was hypochondriacal and intolerant of frustration of any kind, expressed mostly to the nursing staff, whom he treated as though they were combined into one big mother, whose function was to meet his personal needs immediately. His intolerance of frustration was also expressed towards his arm and his rehabilitation regime. He expected and demanded to make a total and complete recovery. He seemed to harbour an intense need to regress and be looked after and cared for, and yet consciously abhorred dependence and vulnerability of any kind. He closely resembled His Majesty the baby. In a word, he was narcissistic. That's a description of our patients. In thinking about this theoretically, what Soames is saying is that the patient has redrawn the boundary of themselves so that they count their limb, which they're not in control of, as part of the external world and not a part of the self, and they treat the limb as though it is in exactly the same way as they treat the nursing staff, as a sort of insubordinate servant that won't do their bidding. And it is hated because it is treated as part of the external world and other and foreign. He talks about this, quoting Freud's Morning Melancholia, describing this as a melancholic or a paranoid, in fact, in this instance, defence against the loss that the stroke represents. So the patient has lost the part of their brain in which whole objects are represented, and what's left behind is the before the development of that bit of the brain where whole objects are represented, the part object, narcissistic way of relating to the stroke. The reason this is important for the subject that I'm talking about is it tells us something about the way narcissistic patients relate to their bodies. So they categorise the parts of their bodies that they're in control of as belonging to the self, and those parts are loved. And those parts which they're not in control of, they classify as other, and those parts are hated. And if they're experienced as being in their own personal space and are experienced as hated, then the impulse is to get rid of them and to attack them. So it gives a bit of a different take on self-harm, doesn't it? Mm-hmm. So I wanted to just use one more non-neurological term before we finish, if that's all right, which is to talk about this phenomenon which is apatemnophilia. So apatemnophilia is a paraphilia. It's an affinity for people who've had amputations, an erotic attachment to people who've had amputations. So apatemnophilia is the attraction to people who've had amputations. Acrotomania is the wish to have an amputation yourself. So a proportion of people who have an affinity for people who've had amputations also want amputation for themselves. And Ramachandran, the same chap who did the caloric test experiment with the stroke patients, who seems to have a bizarre intuition about how the brain works and always asks the right question in his experiments, he noticed people who are acrotomanic, who sought amputations and pursued surgeons to have limbs amputated, that more commonly than not it was the left limb that they wanted amputated and not the right. So he got curious about that as a neuroscientist, and so he decided to get a few of these people into his lab and do some tests on them. He found that firstly they could draw a line on their arm where they wanted the amputation. He said, give you a pen, where do you want your arm amputated? They'd say, right here. This is where I want the surgeon to cut it off. And if you touch their skin below that line, they get a galvanic skin response, but not on the other side. So they find it's aversive touching the limb, and it's not aversive above the line. He put those patients in a scanner and discovered that a number of them didn't have a body image map in their right hemisphere for that limb. So their body image map didn't fit with the way their body appeared. So if you ask them how the limb felt to them, they'd say it feels over-present. That was their term for describing this sense. And that's why they wanted it amputated, because they wanted their actual body to correspond with their body image map in their brain. And they pursued surgeons for amputations. They could not tolerate having something foreign, that felt foreign, inside their physical body space. So I'm arguing that the acrotomania is very like the mysoplegia of the right hemisphere patient, that they hate having a foreign object inside their personal space. So we were talking about this as an example of the sort of xenophobic impulse. Ron Britton's a modern Kleinian theory about the death instinct is that it's a sort of hatred of foreigners. So my argument is that this is a kind of neurological demonstration of the hatred of foreigners, that if you have something that is inside your bodily territory, that feels like a foreign object, there's a wish to get rid of it. So, to summarise all of this, about what neuroscience tells us about how the mind relates to the body in narcissism. So in narcissism, the boundary of the self is redrawn so that those parts of the body that the person is in control of are considered part of the self and are loved, and those which are not are treated as other and part of the external world and hated, and then potentially need to be amputated. That part which is out of control is related to in the same way as other people in the external world. So that's very important for understanding the transference. I've had patients who want to chop off bits of themselves when I go on holiday. It's as though losing me and losing the part of the body are directly equated with one another. The boundary of the self is fluid under the influence of neurological body maps and the dominant anxiety. So with the apotemnophilic patients, it was a body image map problem. But what I'm saying is that because of the way that narcissistic defence mechanisms and all of that stuff about what belongs to whom works, then in narcissistic patients they're redrawing their body maps according to their affective state a lot of the time. So it can be either a neurological thing or it can be a psychological defence mechanism. So to add to that, the self is experienced as territory. What I'm saying about the xenophobic thing is that we count as belonging to us those things that we're in control of, and we count as other those things we're not in control of, and we draw the boundary of the self as the line between what is that we feel we're in control of and what is not when we're narcissistic, and that boundary moves depending on the dominant anxiety, and that is not only a mental phenomenon, but it's the way we experience our bodies too. If the self is experienced as territory in that way, then objects within it are experienced as foreign must be got rid of. So if, for instance, somebody attributes an unwanted part of themselves using attributive projective identification to a part of the body, and then experiences it as other and in the external world, but in their personal space, they will want to have it removed, and they will pursue doctors to get it removed. In narcissistic disorders, unwanted parts of the self are disavowed and attributed to either the body as a whole or parts of the body, which must then be got rid of.